NAFLD, a condition characterized by the accumulation of fat in the liver in the absence of alcohol consumption, is on the rise, mirroring the global obesity epidemic. As more individuals grapple with NAFLD, it has become essential to recognize its implications beyond liver health. In this video, we will navigate through the intricate web of associations between NAFLD and cardiovascular disease, CVD, shedding light on the escalating risks and underlying mechanisms. Non-alcoholic fatty liver disease has emerged as a silent epidemic, affecting approximately 30% of adults worldwide. Initially regarded primarily as a liver condition, recent research underscores its far-reaching consequences. This disease spectrum encompasses everything from simple steatosis to non-alcoholic steatohepatitis, NASH, marked by liver fibrosis and cirrhosis. The connection between NAFLD and CVD becomes apparent when we examine the mounting evidence associating NAFLD with an elevated risk of major adverse cardiovascular events. MACE. Studies reveal that individuals with NAFLD are at a 45% higher risk of developing MACE compared to those without this liver condition. Moreover, this risk escalates with the severity of liver fibrosis, underscoring the importance of understanding the degree of hepatic involvement. NAFLD and CVD share common risk factors such as obesity and type 2 diabetes. These comorbidities further amplify the cardiovascular risk associated with NAFLD. The presence of insulin resistance and type 2 diabetes in NAFLD patients significantly contributes to their heightened cardiovascular vulnerability. The liver plays a pivotal role in lipid metabolism. In the context of insulin resistance, metabolic syndrome, and type 2 diabetes, dyslipidemia takes center stage. This dyslipidemia is characterized by the overproduction of VLDL particles and low HDL levels, further intensifying the risk of CVD. The intricate interplay between the liver, lipid production, and cardiovascular risk is a complex area of study, influenced by genetic factors. Several genes are believed to play a role in both NASH and NAFLD. Strikingly, these genes also influence lipid metabolism, adding another layer of complexity to the relationship. Depending on an individual's genetic makeup, VLDL production may vary, impacting lipid retention in the liver and potentially promoting atherosclerosis. The genetic connection underscores the intricate nature of the liver's influence on cardiovascular health. Chronic inflammation is a hallmark of both NAFLD and CVD. Individuals with diagnosed NASH exhibit lower levels of regulatory anti-inflammatory T cells. Research is now exploring the potential of targeting immune cells as a novel NASH treatment. The liver's immune response extends its influence to cardiac remodeling, creating a bridge between these seemingly distinct organs. Recent studies have revealed a compelling connection between NAFLD, cardiac remodeling, and immune cells. Patients with metabolic-associated fatty liver disease exhibit altered immune profiles, which impact cardiac myocytes and fibroblasts. The interplay between immune cells and the heart highlights the intricate nature of NAFLD's influence on cardiovascular health. Both cardiovascular and liver events are highly correlated with the degree of liver fibrosis. Higher liver fibrosis scores are associated with adverse atrial remodeling and atrial fibrillation recurrence. This observation not only links NAFLD to the classic atherosclerotic model but also directly implicates the cardiac muscle. The potential implications of this connection are driving further research. Heart failure, a condition characterized by the heart's inability to effectively pump blood, has become a pressing public health challenge. It is closely tied to the aging population and is linked to a substantial number of hospitalizations and fatalities. The prevalence of HF surges with age, especially among individuals aged 60 years and older. It's estimated that approximately 10% of people aged 60 and above living in communities have HF, with heart failure with preserved ejection fraction, HFpEF, being more prevalent than heart failure with reduced ejection fraction, HFrEF. NAFLD is a recognized risk factor for major adverse cardiovascular events, MACE, which are the leading cause of death in individuals with NAFLD. Studies have revealed that the long-term risk of developing fatal or non-fatal MACE is heightened in people with NAFLD, and this risk increases with the severity of liver disease, particularly with more advanced liver fibrosis. The association between NAFLD and a higher risk of cardiac complications, including structural, functional, and arrhythmic issues, further underscores the connection to HF. Recent research links coronary microvascular dysfunction to left ventricular, LV, diastolic dysfunction and the future risk of MACE, including HFpEF. Patients with NAFLD have been found to have a higher prevalence of coronary microvascular dysfunction, increasing their risk of MACE over time. Cardiac autonomic dysfunction, which plays a role in HF development, has been observed in individuals with NAFLD. Impaired heart rate variability and other related factors have been noted in patients with NAFLD, with the degree of impairment linked to liver fat content and fibrosis staging. Studies indicate a connection between NAFLD and an elevated risk of arrhythmias, particularly atrial fibrillation, AF, and QTc interval prolongation, which can lead to life-threatening ventricular arrhythmias. This association has been observed in various longitudinal cohort studies. Cardiac remodeling is a pivotal process in HF progression. Strong evidence demonstrates that NAFLD is associated with a higher risk of LV diastolic dysfunction, increased LV hypertrophy, and larger left atrial volume, independent of common risk factors like obesity, hypertension, and T2D. This suggests that NAFLD may contribute to the development of new-onset HF. Community-based studies have shown that elevated serum gamma-glutamyltransferase (GGT) concentrations, indicative of NAFLD, are associated with a heightened risk of incident HF, regardless of other HF risk factors. Research also suggests that NAFLD with increased liver fibrosis scores is linked to higher in-hospital and post-discharge mortality among elderly patients admitted for acute HF. These findings strengthen the argument that NAFLD is a significant risk factor for new-onset HF. Recent advancements in pharmacology offer potential therapies for both NAFLD and HF, given their intricate connection. Several drugs show promise in benefiting patients with these coexisting conditions. Here's a brief overview. Pioglitazone has shown improvements in liver enzymes, liver fat content, inflammation, NASH resolution, and liver fibrosis. Additionally, it reduces the risk of myocardial infarction and ischemic stroke in patients with T2D or prediabetes. However, it comes with some adverse effects like weight gain, fluid retention, and a risk of bone fractures. Glucagon-like peptide-1 receptor agonists, GLP-1-ROS. GLP-1-ROS, including exenatide, liraglutide, dulaglutide, and liraglutide, have demonstrated improvements in serum liver enzymes, liver fat content, and liver inflammation. They also reduce major adverse cardiovascular events, MACE, and all-cause mortality in T2D patients. However, they may lead to side effects like loss of appetite and gastrointestinal issues. Sodium glucose cotransporter 2 inhibitors, SGLT2 inhibitors. SGLT2 inhibitors, such as empagliflozin, dapagliflozin, and canagliflozin, have been linked to improved serum liver enzymes and liver fat content. They substantially reduce MACE outcomes, all-cause mortality, and hospitalization for HF, regardless of T2D status. Side effects may include genitourinary infections, hypotension, and diabetic ketoacidosis. Statins are associated with reduced cardiovascular mortality and morbidity, making them valuable for patients at high cardiovascular risk. They also seem to reduce the risk of new-onset HF, mainly in high-risk patients. However, some patients may experience muscle pain and elevated liver enzymes as side effects. ACE inhibitors and ARBs. These drugs reduce the risk of death, hospitalization for HF, and symptom improvement in patients with heart failure. They are strongly recommended for managing hypertension in NAFLD/NASH patients, irrespective of HF status. Common side effects include cough, hyperkalemia, and hypotension. These pharmacological options hold promise in addressing the comorbidity of NAFLD and HF, offering potential benefits for both conditions. However, each drug comes with its unique set of adverse effects, and their use should be carefully considered in the context of individual patient needs. The connection between NAFLD and the risk of new-onset HF is undeniable, with emerging evidence emphasizing the importance of understanding and managing these two conditions in conjunction. This video has shed light on the intricate association between NAFLD and HF, explored the underlying mechanisms, and discussed potential pharmacological treatments. Healthcare professionals need to consider both liver and cardiac health when managing patients with NAFLD, as this holistic approach can lead to improved outcomes and a higher quality of life.